Your baby is crying. Hard. Face flushed, mouth open wide, that jagged gasping breath between wails that you feel somewhere in your sternum before you fully process the sound. You run through the checklist: diaper, hunger, temperature, the position of their arms, whether something is pressing against their leg. Nothing. And then you notice completely dry cheeks, no tears, not a single one. They are producing what sounds like genuine distress with their entire body, and their face is as dry as it was an hour ago. Most parents either panic briefly, something is wrong with their eyes, or they search it, find something about tear ducts not being mature yet, feel reassured, and move on. Pediatricians confirm it, it's anatomical, it's normal. Lacrimal glands take a few weeks, sometimes longer. Nothing to see here. But that explanation answers the wrong question entirely. It tells you about plumbing. It tells you nothing about what is actually happening inside your baby's brain when that cry starts. And when developmental neuroscientists stopped studying the tears and started studying the cry itself, its structure, its acoustics, its origins deep inside the nervous system, what they found should permanently change how you respond when it happens. Because your baby is not just making noise. And you have been understanding more of it than you ever realize. Most people, if they stop to think about it at all, assume the following. Babies cry because something is physically wrong. They're hungry, cold, wet, in pain, overstimulated. The cry is an alarm. Your job is to locate the problem, solve the problem, silence the alarm. And the tearless part, well, that's just anatomy. The emotion is real, the tear ducts aren't ready yet. Simple. This sounds completely reasonable. It maps cleanly onto adult experience. Adults cry emotional tears. Adults also cry when something hurts. We assume babies operate on the same wiring, just an earlier version, and the tear duct explanation isn't wrong, strictly speaking. The lacrimal glands do mature across the first 1 to 3 months of life, roughly the span between a brand new onesie and the first time the baby fits into the outfit you bought 2 sizes up. That part is accurate. Here's the problem. If crying were purely a physical alarm, hunger, pain, temperature, it would extinguish the moment the problem was solved. Clean, binary, mechanical, switch off. But it doesn't work that way. Researchers noticed decades ago that certain cries don't stop when the physical need is addressed, that some cries begin with no identifiable physical cause at all, that the same baby, in the same physical state, produces acoustically distinct cries, depending on context, distinct enough that adults with no parenting experience whatsoever can reliably tell them apart within moments of hearing them. A mechanical alarm doesn't have that kind of nuance. A communication system does. Your baby isn't malfunctioning. Your baby is broadcasting on a frequency evolution spent millions of years designing you to receive. But here's where it gets stranger. Because when researchers stopped asking what's wrong with the baby and started asking what the cry is actually made of, what's inside the sound itself, what they found in the acoustic data wasn't noise. It was something much closer to a language. Barry Lester and his team at Brown University's Warren Alpert Medical School have spent decades analyzing the acoustic properties of infant cries using a technique called cry spectrography, recording the cry and breaking it down into measurable parameters. Fundamental frequency, cry duration, the latency between cries, the presence of a hyperphonation, that distinctive high-pitched quality that makes a pain cry cut through a room differently than anything else you've ever heard. When you run a baby's cry through spectrographic analysis, you don't get random noise. You get a structured waveform with repeating patterns that correlate reliably with neurological state, not just physical need. The fundamental frequency of a pain cry sits in a measurably distinct range from a hunger cry. The variability pattern of an overstimulation cry differs from the cry produced during social distress. The cry a baby makes not because anything hurts, but because they are alone, and the nervous system has registered that as a problem. These aren't differences visible only to machines. In controlled studies, primary caregivers discriminate between cry types with accuracy, rates reaching 75 to 85%, roughly the same rate at which a physician reads an X-ray after years of training. You are doing something clinically sophisticated every single time you lift your head from the pillow and say quietly, to no one in particular, that one sounds different. Think of it less like a smoke alarm and more like a vital signs monitor. A smoke alarm has one message: something is wrong. A vital signs monitor runs 10 simultaneous channels: heart rate, oxygen levels, respiratory rhythm, each carrying specific differentiated information. The cry is the vital signs monitor. Tearless or not, it is running at full capacity from the first hour. Your baby isn't just crying. Your baby is transmitting a neurological status report, and you have been reading it correctly all along without knowing what you were reading. Now I need to tell you about what happens inside the baby's nervous system in the seconds before the first sound even comes out. Because the cry doesn't begin with the vocal cords. It begins somewhere much deeper. And understanding that origin changes what the tearless cry is actually measuring. The foundational framework here comes from the work of Stephen Porges at the University of Illinois at Chicago, whose polyvagal theory, published in the journal Psychophysiology, provides the architecture for understanding what is actually being reported when an infant cries without an obvious physical cause. The counterintuitive finding, the one that reorients everything, is this. A tearless cry in early infancy is not primarily measuring emotional suffering the way adult crying does. It is measuring the state of the autonomic nervous system. Specifically, whether the infant's nervous system is operating in a regulated state or has crossed a threshold into physiological dysregulation. The counterintuitive part is that this threshold can be triggered not just by pain or hunger, but by something most parents never consider: the absence of co-regulation. A newborn's nervous system cannot regulate itself. This is not a lag in development. This is deliberate design. The human infant arrives wired to co-regulate, to use the proximity, voice, heartbeat, and warmth of a caregiver as external scaffolding for its own internal regulatory systems. When that scaffolding disappears, even briefly, even in a completely safe environment, the nervous system reads it as threat, not as metaphor, as physiology. Cortisol rises, heart rate destabilizes. Vagal tone, the measure of how efficiently the nervous system is self-regulating, trackable through heart rate variability, drops measurably within 60 to 90 seconds of caregiver withdrawal. 60 to 90 seconds is roughly the time it takes to walk from the nursery to the kitchen and pour yourself a glass of water. The cry that follows is not performance. It is a body filing an urgent report about an unmet biological need as fundamental as warmth. Your baby isn't being dramatic. Your baby's nervous system is doing exactly what it was built to do, sounding an alarm when the one thing it cannot survive without, you, is gone. Now, I need to tell you about an experiment that was designed to measure exactly this: what happens physiologically when a baby cries and nobody comes. Because the data is something every parent alive needs to sit with, and it has nothing to do with spoiling. Wendy Middlemiss and her research team at the University of North Texas conducted a study published in the journal Early Human Development, examining what happens inside babies undergoing graduated extinction sleep training, the method where crying is allowed to continue for increasing intervals before a caregiver responds. Parents reported that after several nights of the protocol, the babies stopped crying at bedtime. Stress resolved. Success, by the most obvious measure. Then the researchers looked at the cortisol, the measurable stress hormone, collected through salivary samples from both parents and infants. What they found stopped the straightforward narrative cold. On the nights when the babies were silent, their cortisol levels remained elevated. The babies had stopped signaling. They had not stopped experiencing physiological stress. What changed was not the internal state. What changed was the baby's operating assumption, encoded at the level of the nervous system, that the signal was worth sending. It's worth noting the study had a small sample size and has been debated since, but the underlying question it raises has driven substantial subsequent research. Because the implication holds regardless of the specific numbers, the cry is not the problem to be managed. The cry is the relationship made audible. And here's what that means for you specifically. Every time you respond to that cry, uncertain what's wrong, unsure what will work, you are not simply providing comfort. You are answering a question the nervous system is actively testing. Does distress, when expressed, produce relief? The answer you give in the first year of life is being written into the prefrontal cortex with a permanence that gradually decreases with every month that passes. The window of maximum plasticity does not stay open. Your baby isn't training you. Your baby is asking the most important question they will ever ask: does anyone hear me? and every time you answer, you are writing the word yes into the wiring of who they will become. And now I need to say something important. Because there is a specific change in the cry's pattern, not its volume, not its frequency, something subtler, that developmental pediatricians flag as worth paying close attention to. Not to alarm you, to give you a map. There are two patterns worth knowing. The first is a cry that progressively loses acoustic variability over weeks, becomes flatter, less urgent, more monotone, without a corresponding reason in the baby's physical health or environment. This is distinct from the normal settling that happens as a baby matures. Normal development produces quieter babies because other communication channels open up. This pattern produces a quieter baby because the signaling system has started to power down. The second is a baby who stops crying in contexts where crying would be expected, separation, mild pain, hunger, without being soothed. Silence that replaces distress rather than following comfort. Neither of these is a diagnosis. A single week of change behavior means very little. Babies cycle through phases, have off stretches, respond to household disruptions in ways that temporarily alter their patterns. Every baby's baseline is different, and some babies are constitutionally quieter than others. What warrants a conversation with a pediatrician is a sustained pattern across 2 to 4 weeks, especially when combined with other changes: reduced eye contact, less social smiling, diminished response to a familiar voice. The cry system itself undergoes meaningful maturation between 4 and 6 months. Crying typically peaks around 6 to 8 weeks. This is documented in the pediatric literature and has a name, it is expected, and it ends, before gradually decreasing as eye contact, vocalization, and gesture come online as parallel channels. A cry pattern that plateaus without evolving through this window, or that shows regression after development had progressed, is the specific marker that developmental pediatricians describe as worth discussing. Not diagnosing. Discussing. You have been listening to this particular cry since the first hour of this baby's life. Your nervous system has been calibrating to their specific acoustic signature in real time, every day, in a process no instrument currently replicates. The research is increasingly clear that primary caregivers outperform clinical tools at detecting anomalous shifts in their infant's cry pattern. If something about the cry has changed and you cannot name why, that unease is not anxiety. That unease is the detection system working. Trust it. Make the call. And here's what all of this points to. At the highest level of resolution, the human infant is the most neurologically dependent creature born anywhere on this planet. Other mammals are walking within hours. A human being cannot regulate its own body temperature, its own cortisol response, or its own nervous system architecture for months after birth. This is not a flaw in the blueprint. It is the price of building the most complex brain in evolutionary history, a brain so unfinished at birth, so radically plastic, that it requires an external nervous system to run it while its own is under construction. The tearless cry is not the sound of helplessness. It is the sound of a system operating exactly as designed, reaching outside itself for the one component it cannot generate alone. Every cry is the prefrontal cortex, still being wired, still being tested, sending a signal into the world and waiting to learn whether the world responds. You are not incidental to this process. You are a load-bearing infrastructure. So the next time your baby cries without a single tear on their face, red and gasping and impossible to immediately solve, remember what is actually happening. Their acoustic system is transmitting a structured neurological signal with a precision that trained researchers can measure, map, and analyze. Their autonomic nervous system is reporting a physiological state as real and as urgent as hunger or cold. Their developing prefrontal cortex is recording your response, or its absence, in the architecture that will determine how they move through a world full of other people for the rest of their life. The tears will come. They always do once the glands are ready. But the communication was never waiting on the plumbing, the reaching, the signaling, the radical trust that the broadcast will produce a response. That was there from the very first sound. If you have a baby, or you remember those early weeks, I want to know, was there a moment when you realized the cry had changed, when something in you registered this one is different before you could explain why? Tell me how old they were. Tell me what you did, because that moment has a name now in the literature, And what it means matters far more than most parents ever get to understand. And if you want to understand why your baby reaches for your face the moment they're frightened, not your arms, not your chest, your face specifically, not because they want to be held, not because they're looking for food, but because of something happening in their attachment circuitry in that exact half second that most parents completely misread, that is the next video. And once you understand what's actually going on, you will never look away from them first again.